Hello, I'm Layla Agarwal. I'm a medical oncologist with Norton Cancer Institute in Louisville, Kentucky. Welcome to this program entitled Ovarian Function Suppression in the Treatment of Premenopausal Women with Breast Cancer, highlights from the 2025 Ovarian Function Suppression meeting. In this roundtable discussion, we will explore the latest clinical strategies for ovarian function suppression in patients with premenopausal breast cancer, focusing on current guidelines and evidence, practical considerations, and management of side effects. I'm pleased to be joined today by Susan F. Dent. Dr. Dent is a professor of medicine, director of cardio-oncology, and director of the Judy DiMarzo Cancer Survivorship Program at the University of Rochester in New York. Dr. Dent, thank you for joining us.
Thank you.
We also have Daniela Adi-Blota, a research fellow in breast cancer at Memorial Sloan Kettering Cancer Center in New York. Welcome, Dr. Adi-Blota.
Thank you.
Of note, we're here in Chicago at the 2025 OFS meeting, where we're reviewing new data and insights that will help to advance the field. First, we'll review current guidelines and evidence supporting OFS. We'll also discuss practical considerations for selecting patients and choosing between OFS options. And finally, we will cover current strategies to optimize cardiovascular health, side effect management, and quality of life. Let's start by reviewing current clinical practice guidelines on OFS. Specifically, we have guidance from ASCO, NCCN, and ESMO. Dr. Dent, could you begin by reviewing the data from ASCO?
Certainly, thank you for the opportunity. The ASCO guidelines, published in 2016 on adjuvant endocrine therapy for women with hormone receptor positive breast cancer, really highlighted that for premenopausal women at high risk, often those who are receiving chemotherapy should be offered ovarian suppression with endocrine therapy. So usually when we talk about high risk, we think of stage 2 and stage 3. They also mentioned, however, that even for lower risk women, perhaps stage 1 or 2, there may be considerations that may prompt you to consider ovarian suppression and endocrine therapy, particularly with very young women. Importantly, what ASCO did is suggest that for women at low risk, typically those with lymph node negative and less than or equal to 1 centimeter tumors, those are individuals who would likely not benefit from ovarian suppression and endocrine therapy. And when they talked about endocrine therapy, they mentioned it would be suitable or reasonable to use tamoxifen or an aromatase inhibitor.
Thank you, Dr. Dent. So let's compare this to what NCCN says. NCCN gave some practical considerations for the dosing and the methods of OFS. They discussed the use of GnRH agonists, including goserelin, dosed every 4 weeks or every 12 weeks, which we'll talk more about later in this program. Leuprolide IM or sub-Q, dosed every 4 weeks or every 12 weeks, and triptorelin IM, dosed every 4 weeks. They also mentioned radiation therapy and bilateral oophorectomy as well. In terms of initiation of ovarian function suppression, they mentioned this can be started prior to or with the start of chemotherapy. And if no chemo is planned, then they mentioned to start this alone for 1 to 2 cycles or with tamoxifen until estradiol is in the postmenopausal range, and then consider AI. So this is something as well that we'll touch on as we discuss practical management later in the program. And the duration of ovarian function suppression optimal was determined to be 5 years, but minimum of 2 years encouraged. And they mentioned there's no data on efficacy or safety to support over 5 years of OFS. So now let's review the ESMO guidelines. Dr. Adi-Blota, could you please give us a brief overview?
Sure. ESMO guidelines highlights 3 important points about ovarian function suppression. So the addition of GnRH agonists to tamoxifen or aromatase inhibitor is indicated in patients at higher risk of recurrence. Recommendations for adjuvant GnRH agonists are based on data from trials with monthly administration. That's why current guidelines support monthly injections to optimize ovarian function suppression, especially in very young women under 35 years of age and in those receiving an aromatase inhibitor. And a very important point is about the estradiol monitoring. According to ESMO guideline, the estradiol levels should be checked if there are concerns about ovarian function, if it's not suppressed, especially if there is a breakthrough bleeding and for patients is on AI. So, and in case of inadequate ovarian suppression, alternative strategies should be discussed, such as oophorectomy or continuation of tamoxifen alone.
Thank you both for reviewing those guidelines. So to kick off our discussion, I'd like to ask to what extent these guidelines inform your clinical practice and what are the limitations? Dr. Dent?
Thank you. I think we'll agree that all the guidelines speak to ovarian suppression and endocrine therapy in those patients at high risk. And there's a bit more ambiguity around low risk and who is low risk versus not low risk, and we can talk about that further. But there's also some grayness around when, if you're starting ovarian suppression in the absence of chemotherapy, when do you start that? So if you start your ovarian suppression first, do you add in an aromatase inhibitor a month later, 2 months later? Do you add them together? And we know from some of the data in the metastatic trials, they actually gave ovarian suppression and an AI together at initiation of treatment. So that part is a little bit ambiguous, and I think we probably, as clinicians, need to think about what is the best timing.
That's a great point. Dr. Adiblota, what did you think about the every 4 weeks or every three-month data and the variations between those guidelines?
Yeah, so I really like this topic because this is the topic of my main research project I'm conducting now in my research fellow. So as we can see in the guidelines, there is no a standard for what's the best approach. We should use monthly or 3-month injections. We saw that ESMO guidelines emphasize monthly injections. The NCCN mentioned GnRH agonists every 3 months, and but we don't know. Currently, we have our clinical practice based on the most important studies like soft and text trials where we use monthly injections, but we still have some questions about the efficacy of 3-monthly injections. That's why further studies are needed to address these important questions.
So there's quite a bit of room for variation in practice between these 3 different guidelines. Mm-hmm. So why don't we go ahead and review some of the data that establishes the role of ovarian function suppression. Dr. Dent, can you tell us about the soft and text trial updates that came out earlier this year?
So it's really exciting to see the 15-year outcomes of the soft and text study this year's ASCO meeting. Just to remind everyone briefly, the SOFT study was a 3-arm study in premenopausal women with hormone-sensitive breast cancer comparing tamoxifen alone to tamoxifen and ovarian suppression or exemestane in ovarian suppression. And the TEXT study was looking specifically at ovarian suppression with tamoxifen or exemestane. So when we look at the results of this year's ASCO, what it really does is it really highlights that what we've known up to now remains true. So there continues to be a disease-free survival benefit in women who take ovarian suppression with tamoxifen or exemestane. If we look specifically at the SOFT study to begin with, the 15-year disease-free survival was 67% for tamoxifen alone, 70.5% for tamoxifen and ovarian suppression, and 73.5% for exemestane in ovarian suppression, highlighting again that the benefits we've seen earlier on with previous analysis remain true. There was a small but not statistically significant benefit in terms of decreasing the risk of death. Overall survival was 85.3% for the tamoxifen arm, 86.7% for ovarian suppression and tamoxifen, and 86.9% for those with ovarian suppression and exemestane. When we look at the combined analysis, which again was looking at ovarian suppression in both arms, but one with exemestane, one with tamoxifen, we again see maintenance of benefit with ovarian suppression, in particular in the exemestane and ovarian suppression arm. So the 15-year disease-free survival showed that in the exemestane plus ovarian suppression arm, 74.9% versus 71.3% in the ovarian suppression and tamoxifen arm, again showing the statistical benefit of the exemestane arm. When we look at overall survival, there was no statistical significant difference between the two groups, 87.8% versus 87.0%. But remember, we were comparing ovarian suppression with two different endocrine therapy backbones. So what I think that the ASCO update shows us is maintenance of clinical benefit. And this is really what we want to see. Often trials will show a benefit early on in their analysis, but we really like to see that the primary endpoint, which was disease-free survival, is maintained, showing the benefit of ovarian suppression and AI therapy, particularly in those women at high risk.
It's great to see the long-term follow-up from these ovarian function suppression trials, and we have another study, the hormonal bone effects, HOBO, which looked at ovarian function suppression with triptorelin plus either letrozole plus zoledronic acid, or tamoxifen. And this trial had over 1,000 patients randomized, and we now have the long-term follow-up at a median of 9.2 years. This trial showed that both zoledronic acid and letrozole alone with ovarian function suppression improved disease-free survival over tamoxifen and ovarian function suppression. There was about an 8% absolute gain at 10 years in disease-free survival. These numbers were 75.8% in the tamoxifen arm, 83.8% in the letrozole arm, and 82.4% in the zoledronic acid plus letrozole arm. There was no significant difference in overall survival. I also think it's really interesting and important to look at the toxicities or the side effects, and especially when we're moving from an aromatase inhibitor versus tamoxifen, we're concerned about the effects of osteoporosis. And this trial was specifically looking at the effects on the bone. With these ovarian function suppression trials, it's always important to consider the toxicities or the side effects, and specifically bone health. So this study showed that with ovarian function suppression and tamoxifen, there was about a 6% risk of osteoporosis. With letrozole, which we know increases the risk of osteoporosis, this was 11.6%. And the addition of zoledronic acid, or a bone-modifying agent, to letrozole improved this close to that of tamoxifen, 6.4%. So this shows that the addition of zoledronic acid is protective against osteoporosis. The other interesting part of this study was the interaction with HER2. And so this study showed that the subgroup of patients that had HER2 positive tumor, the results actually favored the combination of tamoxifen and ovarian suppression versus letrozole plus zoledronic acid with ovarian function suppression. So now that we've seen the data, let's talk about the implications, starting with soft and text. Dr. Adi Bloda, what did you think about the data?
So the soft and text trials, the 15-year follow-up show us important data, especially in women under 35 years of age. And we can see a 18% absolute improvement in breast cancer-free interval and 14% improvement in overall survival with ovarian function suppression plus exemestane. And in this specific subgroup, 90% of the patients received chemotherapy. In the combined analysis of soft and text, patients with grade 3 tumors had a substantial benefit as well, with 12% absolute improvement in breast cancer-free interval versus tamoxifen.
I think that's so important that this benefit isn't uniform across the whole group, that there's really these subgroups that are going to be expected to have the greatest degree of benefit. Dr. Dent, what did you think about the data from the HOBO trial?
I think it's really interesting. I was intrigued what you said, particularly about bone health. I think that's something that we often forget about, or we don't pay enough attention to for premenopausal women. We think about it with postmenopausal women. So looking at the benefit of zoledronic acid and adding that in and decreasing the risk of osteopenia, even in younger women, is so important. Because remember, these women have potentially many years of life to live, and we want to try to avoid osteoporosis. So whatever we can do to maintain their bone health is better. So you showed that, there was a gain in benefit in terms of disease-free survival. But not only is the efficacy important, but it's looking at the overall health, particularly bone health here.
That's such a good point. And I think when we're talking about balancing the risks and the benefits, it's important to also note that the group that had zoledronic acid, they did report about a 2% risk of osteonecrosis of the jaw, another side effect that we look at carefully. And that's consistent with other trials that have looked at that side effect as well. So overall, I think this really supports the clinical practice to make risk stratified decisions and really consider the overall health of the patient, including bone health and including other side effects. So now that we've reviewed the guidelines and data on ovarian function suppression, let's talk about what oncologists are doing in practice.
So now we will discuss a very important article published last year in 2024. It was a survey of members of ASCO about clinical management of ovarian function suppression in premenopausal women with breast cancer. More than 200 oncologists participated in this survey, and we saw that there is a variation in clinical practice about ovarian suppression. About 50% of the oncologists use goserelin and 39% use leuprolide in their clinical practice. The GnRH is administered once every month by 46% of the oncologists. Approaches to starting GnRH were varied among the oncologists as well. In terms of estradiol monitoring, around 43% of the oncologists usually measure estradiol levels, and 27% sometimes, and 27% never measure estradiol. The estradiol assays used were standard in 65%, and ultrasensitive method is 16%, and unknown 14%. And most of the oncologists think that interpreting estradiol assay results were considered difficult by 55% of the respondents.
So these survey results, they really raise some interesting questions. In particular, why is there so much variation in practice? Although the guidelines have quite a bit of variation too, which might explain part of that. Dr. Dent, would you like to comment on that?
Yeah, I mean, I think that the Q monthly administration is probably the most common because that's how the original studies were done. When you look at the data and you look back at when people start practicing and they introduce a therapy into their practice, they tend to stick with what they first learned, right? And
yeah, and the ESMO guidelines still prefer the every 4-week dosing.
Absolutely. So in fact, the ESMO guidelines, as you highlighted, say that they prefer monthly, and only if they can't tolerate monthly, maybe switch to Q3 monthly. But we know there's emerging data to suggest at least non-inferiority of the Q3 monthly injections. And we have to also think about convenience for the individuals in terms of coming to centers and what that means in terms of patient care and access as well.
I think there's also a lot more factors beyond that. For example, the age of the patient, what were periods like before starting all this, if someone got chemo or didn't get chemo. So I think there's a lot of individual factors that probably play a role in how oncologists choose between every 4-week or every 3-month dosing.
I think honestly, many oncologists probably would like to prefer to start with the monthly, make sure their estradiol levels are suppressed, and then switch to the Q3 monthly. So maybe, you know, some variation of not just being monthly, not just being Q3 monthly, but some of the fear, I think, for many of us is that if we start with Q3 monthly, we're not going to get adequate suppression.
Yes, I agree with Dr. Dent. I think most of the physicians prefer start with monthly injections and see if the ovarian suppression is under control. But I noticed that most oncologists don't measure estradiol levels in their clinical practice. And about the method, we have the standard method, the ultrasensitive method. We saw only 16% of the oncologists regularly measure estradiol levels using an ultrasensitive method. So there is no guideline, so that's why I think there is a big variation in clinical practice, and that's why we need more studies comparing GnRH agonists every month and every 3 months, and it's important to know about the frequency of estradiol monitoring as well.
I definitely agree, we need more data on this. So can you update us on some new information that's coming out about monthly versus every 3-month dosing?
We saw that the SOFT-NTEX trial shows substantial benefit in disease-free survival and overall survival from adding ovarian function suppression at the endocrine therapy. And in these trials, we know that GnRH was administered every month, but these injections every month result in increased discomfort for patients. However, the potential efficacy of GnRH administered every 3 months remains unclear. So we have here a study published this year. This was a retrospective study using electronic medical data, and around 698 women premenopausal aged 18 to 55 were included in this study. And the patients evaluated received monthly goserelin 3.6 milligram or 3-monthly goserelin 10.8 milligram. And the end point of this study was 12-month real-world event-free survival. The follow-up was at least 1 year. And goserelin 10.8 milligram was observed to be non-inferior in patients who initiate goserelin in the early stage with a treatment difference of 2.3% and in the metastatic breast cancer with a treatment difference of 10.4%. In this study, we saw that more patients who underwent 3-monthly goserelin had estradiol levels below the defined threshold of 2.72 compared with the monthly goserelin when associated with aromatase inhibitor. And for the estradiol analysis, we saw that the patients in the 3-monthly group, around 15% of the patients had at least 1 estradiol levels above the threshold of 2.72, and 40% of the patients in the monthly group had at least 1 estradiol level above the threshold of 2.72 with a p-value of 0.007. So, based on these preliminary data that we presented at ASCO 2023, we designed a new study, randomized phase 2 trial, and I was honored to receive a Conquer Cancer Award to conduct this study at Memorial Sloan Kettering. And this is a phase 2 randomized clinical trial. We will evaluate 50 premenopausal women with hormone receptor positive breast cancer. Patients will be randomized to receive leuprolide every 3 months or leuprolide every month plus one aromatase inhibitor. And all the estradiol levels will be measured using ultrasensitive method, liquid chromatography tandem mass spectrometry at baseline and then at 3, 6, 9, and 12 months during a 1-year follow-up. The primary endpoint of this study is to compare the proportion of patients in each treatment arm who experience at least 1 estradiol level above the threshold of 2.72.
Well, thank you so much for sharing that data. That was really fascinating, especially the fact that in the real-world evidence data you presented, the people who were getting 3-month dosing actually had better ovarian suppression compared to the monthly dosing.
Yes.
I think that's a little bit different than how we might normally consider that in practice, where we would think that the monthly dosing gives a stronger ovarian suppression. So that's really fascinating, and I'll be so interested to see the results of that trial come out, and hopefully, that may be able to give people more confidence to space out to the every 3-month dosing. Dr. Dent, what do you think about these findings about monthly versus every 3 months?
I think this is a very important study because we have assumed that the monthly dosing was the best based on previous clinical trials. But if we can get the same efficacy or maybe even better efficacy with 3-month dosing, that means more convenience for the patients, less visits to the cancer center, access issues. So I'm always thinking, what if we can get the same efficacy with less intervention? To me, that's actually improving patient care. So important. And also the question about when do we measure estradiol levels and what's the best assay? I still, as you highlighted, is an open question. We need more and better information and guidance on how to do that.
Yeah, thank you, Dr. Dent. We are very excited about this project because we can answer 2 important questions. First, the GnRH regimens, monthly versus 3-monthly. And also, we will measure estradiol blood levels using an ultrasensitive method, liquid chromatography tandem mass spectrometry. So we can see the trajectory of the estradiol levels during a 1-year follow-up using an ultrasensitive method, and then we maybe in the future we could standardize the guidelines and help oncologists to best manage ovarian suppression in their clinical practice. And of course, we can provide better convenience for patients, a better treatment adherence, and quality of life for patients as well.
Such a good point. And I think, one question I always have is if there's a transient estradiol elevation, what does that actually mean for the prognosis of the patient? Do we know that it's harmful? How often does that estradiol have to be elevated for us to worry about the outcome? And I think that your trial and others that are coming out are going to give us more information and more confidence in interpreting those estradiol results and counseling our patients based on those results as well. So now let's move to the final portion of our discussion where we'll focus on key issues related to side effect and the impact of these treatments on the patient. So managing these toxicities is a major focus of our discussion at the OFS Summit, and this includes talking about sexual function and related side effects and cardiac risk. Dr. Dent, you are giving an interesting presentation on navigating the cardiac risks of modern breast cancer treatments. Could you provide us with some details on this issue?
So thank you for giving me the opportunity to talk about cardiovascular risk in women with breast cancer. It's something I'm very passionate about. We know the use of aromatase inhibitors in postmenopausal women is associated with increased cardiovascular risk because we're lowering their estrogen levels are already postmenopausal. We're making them super postmenopausal, so they're more prone to hypertension, dyslipidemia, and atherosclerotic heart disease. But what is the impact of lowering estrogen levels and making premenopausal women postmenopausal women, especially for a period of 5 years? And then you add in, an aromatase inhibitor. So you're lowering those estradiol levels extremely low. Unfortunately, the clinical trials to date have really not explored the cardiovascular impact of making premenopausal women postmenopausal or lowering those estradiol levels extremely low. There was, in fact, a recent systematic review looking at trials that have been published to date. 2 of those trials, 4 trials, 2 of them included soft and text, actually showed that ovarian suppression and endocrine therapy, particularly aromatase inhibitors, were associated with a higher risk of cardiovascular events in premenopausal women, specifically hypertension. So again, it's not something we often think about, but we can potentially be causing hypertension or worsening of hypertension if they already have it in premenopausal women. And the question is, what is the long-term impact of hypertension if we're keeping them in that state for 5 years or longer? So what I've seen in the literature to date is there's really a pressing need to understand the cardiovascular risk factors for these young premenopausal women at high risk who we place on ovarian suppression and AI therapy. And of course, we can also add in there, what about CDK4/6 inhibitors? And we add that on top, and there's some cardiovascular implications from those drugs as well. So at this year's ASCO, there was an abstract that looked at, it was in older women, so it wasn't premenopausal women, but it just sort of highlights some of the issues that we face. So this was looking at women that were hospitalized for breast cancer. They looked at those women who had cardiovascular risk factors versus those who did not have cardiovascular risk factors. And what they found in this data set was that women with breast cancer who had cardiovascular risk factors had higher incidence of cardiovascular related deaths. In other words, not surprisingly, the increased risk of mortality. So again, this study was in postmenopausal women, but we need more data understanding what is the impact in the premenopausal women. In fact, I just told you there was not a lot of data, but recently there was an article published in a journal called JACC Cardio-Oncology. It was a market scan real-world database study. And what they did is they took women all premenopausal between the ages of 18 and 55 with breast cancer and no history of cardiovascular disease. And they looked at those women who were on ovarian suppression and an aromatase inhibitor, and they compared them to those women on tamoxifen. The primary outcome was a composite cardiovascular outcome consisting of atrial fibrillation, myocardial infarction, stroke, hospitalization for heart failure, and angina or coronary revascularization. The secondary outcomes for the study were hyperlipidemia, the incidence of hyperlipidemia and hypertension. And then they did propensity score matching used to balance treatment groups across confounding variables, breast cancer, age, treatment, and comorbidities. And so there, in this study of close to 5,000, over 5,000 women in the tamoxifen group and just over 1,000 or more women in the aromatase inhibitor and ovarian suppression group, they had a median age of 44.8. So these were younger women in the tamoxifen group versus the 43.7 in the AI and ovarian suppression group. They included, by the way, also women with metastatic disease. Median follow-up was short, so 1.57 years in the tamoxifen group versus 1.5 years in the AI and ovarian suppression group. And what they reported is the overall incidence of cardiovascular disease was low, so not surprisingly, because it's short-term follow-up, younger women. But when they looked specifically at the AI and ovarian suppression group, the risk of cardiovascular disease was much higher. The hazard ratio was 2.2. So women were twice as likely to experience a cardiovascular event based on that composite endpoint that I discussed earlier than women in the tamoxifen group. And there was a 49% increased risk of hyperlipidemia. These things, we know, are risk factors for cardiovascular disease. So interesting study, retrospective study, real world data, but just kind of giving us a hint that we really maybe need to be paying attention to some of the cardiovascular risks associated with these therapies, particularly with ovarian suppression, as we're making them I call them super postmenopausal at a young age. What is being done to sort of evaluate the risk, the cardiovascular risk? And I was very fortunate to be a part of this study, which is very close to meeting accrual. It's called the CROWN study, which is the study of cardiac outcomes of women with near complete estrogen deprivation. So what they're doing is they're taking a cohort of women who are being treated with ovarian suppression and an aromatase inhibitor or tamoxifen, and there's a second cohort of triple negative breast cancer patients, which will sort of be the comparison group, and following them for a period of 2 years, looking at specifically what are some of the changes happening in the coronary vasculature. So in this study, the primary aim is to understand the evolution of cardiovascular injury, as well as biomarkers and demographics that correlate in young women with breast cancer treated with near complete estrogen deprivation, with the ultimate goal of developing the ability to assess and mitigate cardiovascular risk. These women will be undergoing investigations, including blood work, but importantly, CT angiograms. So they'll be looking at their actual coronary vasculature, as well as they'll be undergoing cardiac MRIs to look at to see if there's any changes, which is a little bit different than what we're used to. We're looking at sort of like hypertension, dyslipidemia, but they're actually going to be looking at changes in the structure of some of these. So it's a very interesting study and exciting to sort of see what might happen with the results of the study. It'll certainly give us more information about things that we might be seeing in these women.
This is such an important topic, and especially, we're causing ovarian suppression, we're inducing menopause in these young women. We have information about what is the benefit in terms of breast cancer disease-free survival, but there's no overall survival benefit overall, reported in that population. So I think it's also important that we're balancing that against not only the day-to-day toxicities, but also longer-term toxicities like cardiovascular health. Is there any information about what we could do to mitigate these cardiovascular side effects?
So yes, we are starting to see data emerge on how we can improve the cardiovascular health, not only of postmenopausal women, but premenopausal women. So at this year's ASCO, again, there was another poster looking at the impact of exercise as an intervention to try and improve cardiovascular health. Now that was sort of a secondary endpoint, but in this study of 75 women with early stage breast cancer, they were randomized to a structured exercise program, in this case, resistance training, versus just giving information to the other group of women and following them. And they were looking specifically at muscular strength, but also as secondary endpoints, they were looking at health-related quality of life, range of motion, as well as cardiorespiratory fitness levels. And what they found is that in the women who were randomized to the resistance training, which was 2 sessions per week for 12 weeks, those women improved in terms of their overall health-related quality of life, body mass index, muscle strength, and importantly, in their cardiorespiratory fitness level. And I think this is so important because we know that when we give systemic therapy to women, and then now we're going to add on perhaps endocrine therapy and ovarian suppression, that we lower their cardiorespiratory fitness level. We actually decrease it, and there's good data to suggest that. So now we're seeing data emerging to suggest that exercise might be a good thing. It is a good thing to do even during your treatment, while you're on treatment, rather than waiting until afterwards. I mean, how often do we hear women say after their treatment they're so fatigued, they are so deconditioned? So we need to try and encourage people to think about that during their treatment.
Thank you, Dr. Dent. That's an excellent discussion about the key importance of cardiovascular health. And I think it's a good time to talk about other side effects and other toxicities that we see with ovarian suppression. And one of the ones that we know is can be very profound are the sexual health changes that come with ovarian function suppression. And not only do we know that these are very common and they are very distressing to our patients, often we don't talk about it. It's something that doesn't always come up. And yet when we're prescribing and giving a patient ovarian suppression, we know that we are going to be inducing changes that are called the genitourinary syndrome of menopause, where vulvar dryness, vaginal dryness, decreased lubrication, loss of elasticity, even issues such as vaginal stenosis, which is narrowing and shortening of the vagina, all of these can impact sexual function. In addition, you talked about cardiovascular effects, what patients go through. There can be other changes such as weight gain, body image concerns. People have gone through multiple different breast surgeries and other treatments, and it's really an area I think that patients are very concerned about, and we can really do better in terms of addressing these sexual health changes. So some of the things that I talk about often include upfront discussion that these changes are going to occur, utilizing moisturizers and lubricants, and then talking about vaginal estrogen as a treatment to manage the genitourinary syndrome of menopause, which is actually addressed in several guidelines, including ASCO and others, that this is something that can be utilized in the context of what they called shared decision making. What's your experience with your patients talking about sexual health and how that can impact them?
It's a big issue. It's definitely a big issue, particularly if you're taking a woman who's 35 years old and you're making her feel like a 55-year-old. And she is maybe in the prime of her life, maybe in a new relationship, and there's so many sort of issues and psychosocial issues around that, and now you're making her feel older. So what we do, at least in our centers, we have a sexual wellness program. So we try and get them engaged with these individuals right from the very beginning, rather than wait until they develop symptoms or run into trouble, because we know that this is going to be an issue for those women. And I think, as you said, body image is important. They may gain weight, which is also not a desirable side effect. Mood changes, cognition changes that, women experience during menopause, they may experience as well. Urinary tract infections as well as can be common. And so there's so many things. And so I think what you really need is a good multidisciplinary team to help you, because I think we as oncologists, we cannot provide all the best services for these individuals. But if you have a sexual wellness program, you have maybe access to exercise, all of these things, yoga, mental health programs. I think everyone will have different needs, but I think it's important thing is identifying those needs, and I think being more proactive up front, realizing that people can benefit from trying to prevent some of these things, because we also know adherence is a problem. So if people are experiencing severe side effects from that treatment, adherence is going to be poor, and so they will not stay on the therapy. That may actually give them better clinical outcomes because of the side effects.
Yes, I totally agree. I think it's very important to have a control of the side effects during the treatment, especially with young patients. We know that they face a lot of problems with sexual health, and it's important to have a multidisciplinary team. And more studies focus on that as well. So, for example, comparing monthly versus 3-monthly injections in my study, it's a research not only to evaluate the efficacy of a treatment, but also to give a better convenience for patients, more quality of life it helps. Like it's much better to receive monthly, 3 monthly injections than injections every month. And we know that the ovarian suppression and endocrine therapy are related to a lot of other side effects as well. And that's why we need to move forward with more studies focused on adverse events, quality of life, not only evaluating only efficacy of a treatment, that it's very important as well, but we need to focus on the quality of life of the patients, because it's very important in terms of treatment adherence as well. And we need this type of studies for to improve our clinical practice and give more quality of life for breast cancer patients.
And if I can just add one point to that, because I think this is so important, vaginal estrogen, which you mentioned, I'm still getting people coming to my practice where they've been told, no, you can never take that, that's bad, no estrogens. This is so vital to vaginal health. And so I think it's really important we get that message out that yes, we know there's data now to say you can use vaginal estrogen. So I think that's an important message that I wanted to add.
Thank you both for such a lively discussion on the important issues today. In summary, we can say that ovarian function suppression improves outcomes in high-risk premenopausal breast cancer patients when combined with endocrine therapy. There's growing data for the efficacy of extended dosing of GnRH agonists. Shared decision-making is crucial to improve adherence and address quality of life issues. Supportive care and proactive symptom management may help reduce treatment discontinuation. And as we improve outcomes with ovarian function suppression, we need to consider the impact of the whole person, a person-centered approach which requires a multidisciplinary team. Thanks to you both for this great discussion.
Thank you.
Thank you.
And thank you for participating in this educational activity. Please continue on to answer the questions that follow and complete the program evaluation to earn credit.